for this invitation. It's my honor to be today among my colleagues, professors, and brothers to share this nice topic. First of all, I would like again to thank you. I have seen many endosonographers worldwide, and by far, Dr. Hassan, you are a legend. I have to say this. I give you all my respect and appreciation, really. I will start my topic today about EUS drainage of peripancreatic fluid collection. So it is a very important issue, and I personally, I do it with some passion. I started this technique about 12 years ago in Egypt. I saw patients suffering and dying from after acute pancreatitis. At that time, this subject was a little bit new, and it have not been done in the Middle East at that moment. And I remember 3 cases died in front of me without any interventions, and that's why we decided to start it. And at that time, we didn't do it with endosonography, we did it with endoscopy, depending on the bulge, which now when I think about it, it was really crazy idea. Of course, it was not our idea, it was already many trials before us. And we started this technique, and now we have the endosonography, a marvelous instrument that allow us to do many things. So I will start now. Like any subject, any technique, the first thing we have to know is to understand the etiology, the mechanism of the lesion, why we have this problem, in order to have a better plan how to manage it. So the etiology of peripancreatic fluid collection in general, we have the most common cause is acute pancreatitis, which is acute pancreatitis is a huge subject. Of course, I will not cover it today, but how to manage these patients, especially patients with severe acute pancreatitis. Acute pancreatic fluid collection can be a result of severe acute pancreatitis, the most common cause, or post-operative leakage. I will put my concentration today about the management of peripancreatic fluid collections after acute pancreatitis. And what are the causes of acute pancreatitis? Most common causes are biliary and alcoholic causes, or other causes like increased triglycerides, calcium, trauma. Trauma is also common, pancreatic duct obstruction with stones or strictures, or idiopathic. Okay, what is the pathogenesis of acute pancreatitis? What happens? Actually, we don't understand it till now, although there is many reasons, known reasons, but we don't understand 100% the pathophysiology and the pathogenesis of this mechanism. In my hospital, there is a big laboratory. They spend, I think, every year more than 15 million euros just to understand this mechanism, and it's till now it's not completely clear. But the most acceptable theory is the premature activation of pancreatic enzymes. What happens? We have the acinar cell having the inactive enzymes, the lipase, trypsinogen, etc. We have an insult, causative factor, increased pressure in the bile duct, trauma, the cause. I believe most of the causes are drainage problem. Either with trauma, with a stone, with stricture, it is increased pressure in the pancreatic duct that will cause a trauma to the acinar cells that will activate the trypsinogen, and the trypsinogen will activate the other enzymes. So the duct might be disrupted, and activated enzymes, which are made to digest meat, to digest proteins, will be released in the retroperitoneal area and causing the damage. From fat necrosis, which will cause hemorrhage, to coagulation and necrosis, etc. Also, at that procedure, this process, cytokines will be released, and this is the cause. Acute pancreatitis is not an organ disease; it is a systemic disease. Sorry. So we have to differentiate the different types of peripancreatic fluid collections. For many colleagues, even here in Germany, in my hospital, or around the world, I hear always they say he has a pseudocyst. Is it the right terminology? We have to understand that there's different fluid collections. And why this is important? Because our management, our strategy will differ and depend on this concept. So after the pancreatic duct disruption and the fluid came out, or it can be also an exudate, strong exudate, we have something called acute pancreatic fluid collection. It is not capsulated, it is just free acute peripancreatic fluid collection. In more than 50%, in other papers, till 70%, that will heal or will have spontaneous resolution with conservative management. The rest, within 4 weeks, a capsule will develop. If there is no necrosis inside this fluid collection, and that means that the enzymes were not yet activated when they came out in this area, or we will have necrosis if the enzymes were activated. If this non-necrotic collection is still sterile, we will call it pancreatic pseudocyst. If it is infected, we will call it pancreatic abscess, but still we don't have tissue inside. So a pseudocyst can be infected and then it will be an abscess. Or it will have, which will be walled-off pancreatic necrosis, either sterile or infected. So we can imagine it like this. We have the pancreatic duct. It will disrupt or sometimes just a strong exudate. And at the beginning, it is free, and then it will be encapsulated. This is an example. Of course, it is not recommended to do this. This is a picture from Qasr Al Aini Hospital, I think 12 years ago, during acute pancreatitis. And we see here the leakage. These areas will develop in the future, the pseudocyst, that what we see. Still not a pseudocyst, as we see, it is inhomogeneous, irregular picture. With walled-off pancreatic necrosis, as we can see here, the enzymes are activated, tissue are digested and will become necrotic. I have to say something. Pancreatic necrosis is not actually pancreatic necrosis. The pancreas organ is not that big. We saw cases with 16 or 18 centimeters necrotic tissue. Of course, this is not the pancreas. It is the fat tissue, which has been digested with active enzymes. This is the possible route. So we said that the fluid will come out, the secretions will come out from the pancreas, and this is the common routes for this fluid collection. It is mostly retroperitoneal. It can go in the gastric area, behind the duodenum, even down to the pelvis. The diagnosis, we can see it with abdominal ultrasound. Of course, CT is the standard modality to really measure and judge the fluid collection, MRI, and endosonography. Endosonography, of course, in this field is a game changer. Endosonography in the field of peripancreatic fluid collection changed everything from the diagnosis till the... This is an example of ultrasound, abdominal ultrasound, normal abdominal ultrasound. We can see the fluid collection with some necrosis inside. This is a CT. We see a 12 centimeter fluid collection. This is an endosonographic picture of pseudocyst. It is encapsulated. It is homogeneous, not free of echoes, but still homogeneous, no necrosis. And this here is a walled-off pancreatic necrosis. It's clear. Of course, sometimes in many or in some cases, it is difficult to say if this is walled-off pancreatic necrosis or pseudocyst. At this point, we have to put in consideration that necrosis might be inside. When to intervene? Okay, we have the fluid collection. It is organized, encapsulated. When to intervene? With asymptomatic fluid collections, should we intervene or not is still debatable in the literature. I would say if it is smaller than 4 centimeters, then leave it in peace. If it is big or getting enlarged with time, you have to intervene. Infection is the most common cause for intervention. Pain, gastric outlet obstruction because of the compression on the biliary system causing cholestasis. We have to intervene if the patient is not doing well, even if we don't see clear signs of infection. We can intervene. When early versus delayed drainage, the rule of wait for 4 weeks to have an organized collection, to avoid complications in general. It is still debatable. Literature, there are some case reports from 1 week. I myself, I drained collections after 2 weeks. they went fine, but I would always try to wait this 4 weeks as much as possible. In some cases, you can put an external drainage, but that we will discuss soon. We have to notice if you are sure that there is necrosis in the cyst, you can't leave it, because infection of walled-off pancreatic necrosis can develop in 70% of cases. If you don't intervene, mortality rate is 100%. And I witnessed here, where I work, that they dismissed the patient wants to go home, he has walled-off pancreatic necrosis, but no signs of infection. The patient is doing well, his labs completely normal. And what happens always, this patient will come in the near future with sepsis and many times with perforated organ like colon. Treatment options: if we know that this is a pseudocyst or abscess, drainage is more than enough. EUS versus percutaneous drainage. In many studies, EUS was superior than percutaneous drainage, with less complications, less incidence of fistula, percutaneous pancreatic fistulas. Favorable for the patient. The patient is not doing well because pancreatic patients with acute pancreatitis, they already depressed when they reach this stage, when they wait 4 weeks. It is 100% in all patients, they will be depressed. They have depression. And putting external drainage, 2 or 3 tubes coming out of his abdomen, is bad life quality. Consider percutaneous drainage in special cases. Okay, if it is walled-off pancreatic necrosis, standard therapy is debridement. Necrosis, always necrosectomy. It is the only treatment. How to do it? Open necrosectomy was standard before, with mortality rate till 95%. So I think it doesn't make any sense to give a patient 5% chance. It was substituted with laparoscopic necrosectomy with mortality rate of 15%, which was accepted a little bit, but of course the hospital stay was very long. Also, videoscope assisted retroperitoneal debridement by making 4 centimeter incision and just trying to debride the retroperitoneal cavity. And of course, we have the endoscopic necrosectomy. Which is better? This is the PANTA trial from the Dutch group, a great group in Holland. They are doing very big studies about the pancreas and pancreatitis, and they published in 2010 this very famous study. This is step-up approach study, where they compared the step-up approach means that they delay, they will wait, they will drain, and they will debride, but they didn't do it endoscopically. They did it with minimal invasive surgery. As I told you, they made an incision and then to the retroperitoneal, and then they do the debridement. And of course, it was superior than open surgery. It was published in New England. It's now in the guidelines, no open surgery for such cases. But which is better, endoscopic or minimal invasive surgery? This tension trial from the same group was published in The Lancet in 2018. Endoscopic necrosectomy was superior to minimal invasive surgery in which aspects? It has lower incidence for of cardiovascular failure. It has lower incidence of pancreatic fistula. It has shorter hospital stay, but it was equal regarding mortality and complications, which shows us that endoscopic necrosectomy is already a better modality or therapeutic modality. Okay, we decided we will do endoscopic drainage or intervention. How to do it? With drainage, we will do interventional endosonography. We need it. We need CO2. Never do it with air because there is many case reports of air embolism. Under fluoroscopic guidance, we prepare your puncture accessories, 19G if needle, cystotome, guide wire, plus minus balloon. It depends if you have cystotome with 10 French diameter or not. I will tell soon why. And of course, your drainage, the stents, double pigtails, nasobiliary. Actually, in literature, they didn't show any advantage to put nasobiliary and to wash the whole time. This is an example of I showed this picture earlier. This is the endosonography. As we can see here, we have the necrosis. Here is the cyst. You come with the endosonography, with EUS device. You puncture directly from the stomach. You give contrast. First thing you have to do is to withdraw or aspirate a few millimeters for microbiology and culture. And then you give contrast metal to make sure that you are in the right collection. I witnessed also people punctured many times in the gallbladder. They thought it is the cyst. You put your wire, make sure that you make 2 loops at least with the wire. You see the wire is looping twice because you will do many maneuvers in the next few minutes and you don't want to lose the wire. So keep it deep in the cyst. Here's the wire from the stomach, a guide wire. Then you pass your cystotome. This is a 10 French cystotome, which has an advantage that you can pass 2 wires. There are different cystotomes in the market. Choose whatever you feel confident with and make sure that it will allow the passage of 2 JAG wires. After we insert a second wire here, we come out with the cystotome, we insert our first pigtail, our second pigtail, and it will evacuate quickly in the stomach. Make sure if you will do drainage, if the cyst is too big, the evacuation can be very strong that the patient can aspirate. Just make sure and be prepared. If it is with pancreatic necrosis, we have to do debridement, which means we will go a step further. We will do adequate balloon dilatation because we will have to go inside the wall of pancreatic necrosis with our endoscope. So usually I do dilatation between 15 to 20 millimeters for viewing endoscope, and you can use multiple accessories to achieve your necrosectomy. We did a study in Egypt 10 years ago. We used hydrogen peroxide. It is published many times afterwards. Many centers are using it. It helps with the necrosectomy. It decreases the sessions and the effort you need. CO2, as I said, it is a must. You can never come inside the retroperitoneal cavity with air. Drainage, double pigtails, as I told you, nasobiliary has no advantage. So you insert the wire in the cyst or in the cavity. You do balloon dilatation. Here's the balloon inflated. Then you deflate the balloon. You remove it, and you come inside the cavity. Here is a cavity with a lot of necrosis. Here we are using a snare. You can use snare. You can use forceps. Just be delicate and be cautious that you'll never know what is behind the necrosis. You can erode a vessel or make a heroic bleeding. After you take all the necrosis, you put pigtails. This is the same necrotic cavity after it is finished. That's what we want to see every time. A very fine granulation tissue that easily bleeds with touch. This is very important for the healing afterward, that the cavity will collapse. Nowadays, we have this lumen opposing metal stents. For example, the hot axial stents. There are many stents are coming now in the market. It is a stent that has on its tip a cutting ring or a ring needle through which you can cut the mucosa and the whole wall of the stomach and come inside the cavity, through which you can put also a wire after you puncture, and then you deploy it from this side. And I don't know if you can see it now, but anyway, I will play a video now that will show how to use it. This video you can also find on the internet. It is from the company. So it has a handle. This handle has 4 marcated steps from 1 to 4. You put it exactly like the fine needle inside the endoscope. Here we are in the stomach. They puncture at first and they put a wire with a needle, and then they come inside the fluid collection. They open, they lock the first phase, and they'll go to the second phase, which is the deployment of the distal part of the stent, which will be inside the cavity, and then you pull back and deploy the external part of the stent. Here's a real example. This is this is here fluid collection, retroperitoneal from the stomach. We see it with endosonography. Now we are coming inside. We are giving cutting with electricity to come inside. Now we will deploy the inner part of the stent. So it is like a dumbbell-shaped stent. You pull it back till you hit the wall. You can see it very nicely under endosonography. At this stage, you can deploy the external part. Now we will switch to endoscopic picture here after the deployment. Yes. What is the advantage of this stent? This stent, at least here in Germany, it costs 4,000 euros. I think like something like 80,000 Egyptian pounds. What is the advantage? The advantage, it is quick, of course, so you don't need to change needle, cystotome, pigtails. And second advantage is it has diameters between 10 till 20 millimeters. So you can come inside and outside. It works like an open valve the whole time for you to come inside and outside the cavity. With pigtails, every time you will start a new session, you have to remove the pigtails, do dilatation sometimes to come inside. At the end, you have to put pigtails. Here it is quick. I myself, I'm still a big fan for necrosectomy. I'm still old school fan. I like to work mostly with pigtails because I feel with the axis that I'm a little bit restricted. I can't move with my endoscope to achieve full necrosectomy. What is new? We have this something called endorotor. It works. Sorry, the technical description is in German. It is, as we see here, this the tip of the device works like a vacuum cleaner with a knife that rotates very quickly. So it sucks and cuts, sucks and cut. So actually, it is like a vacuum cleaner. Let's see here this patient. This is the device. You put it and you push your pedal, and it starts sucking the necrosis and cut it. Actually, this device was developed for mucosectomy, but then the company is now marketing for it for necrosectomy. Do I like it? Sometimes I feel it is very useful, especially if the necrotic tissue is very muddy. Sometimes you have, I call good necrosis and bad necrosis. Good necrosis, you can just remove big bulks from it. And bad necrosis is something like what we see now. It is more like a mud. You can't really catch it. Here, after we finished it with endorotor, I didn't do many cases with this device. I think we did something like 20 cases or 25. So I only use it when it is something like this necrosis. Conclusion. EUS guided drainage and debridement is superior to surgery. It is clear. Percutaneous drainage should be considered as complementary or first option only in special cases when we believe that endoscopic is not doable or difficult, or we should wait. Type of fluid collection will determine the treatment strategy. That's why it is very important to understand the etiology and the pathogenesis of the disease. The peripancreatic fluid collection should be managed in interdisciplinary team. I usually discuss such cases with a good radiologist, a good surgeon. We have to not to forget that this patient or pancreas is pancreatitis is a systemic disease. It is not only the necrosectomy, not only the drainage. He should have full supportive therapy, antibiotics, fluids, whatever, ICU if he needs. And don't forget, delay, drain, and debride. Thank you very much. Any questions?
شكرا جزيلا دكتور محمد. يعني لو تسمح لي سؤال صغير عند حضرتك.
اتفضل.
حبيبي ربنا يكرمك. انا بس عشان عايز اتاكد من معلومه حضرتك قلتها.
Please speak in English. Please speak in English, Dr. Khalid.
Okay, I would like to ask about a small question. Sometimes it is difficult to differentiate between sterile walled off necrosis and infected necrosis. And what's your strategy in your hospital?
It will not make a difference between sterile or infected. Doesn't make difference. You will drain. You will put pigtails. That would be your strategy. So it will not change your plans if it is sterile or infected. What is important is there is necrotic tissue inside or not, because that will make you to plan for necrosectomy.
So according to, I think, ACGE guidelines, it is recommended not to touch sterile necrosis, right?
No. It depends. Sterile, what you mean with the sterile? With clinical picture, with labs, or with
yes, with clinical picture and labs. Sometimes it is clear that there is only asymptomatic.
Yeah, my experience, if it is a big necrosis, if we're talking about more than 6 centimeters necrosis, it is very difficult to see such non-infected necrosis. I didn't see it till now. It will be infected at one time or another. 6 centimeters will never heal spontaneously.
Okay. There's another question. Sometimes it is difficult to target the lesion from the stomach. You know, as you mentioned, diffusion of the necrotic tissue and the fluid component. Sometimes it is in the right iliac, in pelvic. I saw 2 cases like this, and it was difficult to target it from the duodenum or the stomach. What's your management at that time?
Then you will have to go for percutaneous. If it is not in your range, then this is one of the special cases I would send for the percutaneous. If it has necrosis, but this is very, very, very rare cases.
Yes,
most of the cases, yes, that it is isolated down. It will be very rare, and usually they are not full of necrosis. Such cases, usually percutaneous drainage will be sufficient for such cases. If they have necrosis, you can go for percutaneous endoscopic necrosectomy. You will dilate it with the bigger drainage till you have a good diameter. Then you can go with endoscope, but also with a delay. So you can dilate every 2 to 3 days.
Okay. Much thanks.
Thank you very much.
So I'd like a very nice debate, very nice debate between Dr. Mohamed Abdel Hafez and Dr. Khalid Rajab. But we should stress on that walled off pancreatic necrosis is very rare to